6,000. That's the number of American women who enter menopause every single day.
It is a massive transition, you know? I mean, half the global population goes through this inevitable biological shift. But the reality of how we handle it clinically is frankly astonishing.
Right. And here is the statistic that completely threw me when I was looking through our sources for today. Over the last 2 decades, the medical treatment of menopausal symptoms has actually sharply declined.
Yeah, it's gone way down.
Like, we have more women entering this phase of life, living longer than ever, but somehow we are treating them less. If you are listening to this right now and you or maybe a partner or a friend have ever gone to the doctor asking for help with debilitating hot flashes.
Or brain fog, which is a huge one.
Exactly, brain fog.
Yeah.
And you go in only to be handed a prescription for an antidepressant instead of hormone therapy, well, this is exactly why.
Because that decline in care, it isn't an accident. It is the direct result of a very specific, incredibly messy history that has left both patients and, honestly, a vast majority of doctors completely confused about what is safe and what is dangerous.
Which is exactly why we are doing this deep dive, because today, our mission is to untangle this fear-driven history of hormone therapy and shortcut your journey to being truly well-informed.
Right.
We are basing our conversation on a really comprehensive 2024 clinical review from obstetrics and gynecology, alongside some fascinating clinical data on testosterone implant therapy. And we're going to shatter a lot of what you probably think you know about hormone replacement.
Yeah, we're moving way past the direct-to-consumer snake oil, the confusing Instagram ads, and the outdated fear-mongering.
Yeah.
We're looking at the hard, objective science here. Our goal today is to give you the why behind the shifting medical guidelines. We want to provide the actual physiological and statistical context so you can understand the science from the ground up, rather than just reacting to the headlines that have dominated this conversation for, 20 years now.
And to really understand the landscape today, we have to look back at the absolute bomb that went off in women's health in the summer of 2002. Because before 2002, hormone therapy was standard practice.
No, absolutely. Women were taking it. They felt great. It was totally accepted.
And then, almost overnight, prescriptions plummeted by a massive 79%. I mean, women literally flushed their pills down the toilet. And it all traces back to 3 letters, the WHI, or the Women's Health Initiative. So, okay, let's unpack this. What exactly happened to cause such a massive panic?
Right. So the WHO was a massive government-funded trial. We were talking a $600 million budget involving over 160,000 women. Yeah, it was huge. But the primary goal wasn't actually to treat hot flashes. It was a preventative medicine study to see if hormone therapy could prevent chronic diseases, specifically cardiovascular disease, as women aged.
But wasn't the WHI considered the absolute gold standard of clinical trials? How could it cause such a panic if it was the gold standard?
Well, in July 2002, before the study was even completed, the organizers held a major press conference to announce preliminary findings. And the message they delivered to the public was terrifying. They announced that the hormone therapy they were testing actually increased the risk of breast cancer and cardiovascular events.
And that obviously made global headlines instantly.
Instantly. And it completely changed medical education. The doctors who trained in the 20 years following that press conference were basically taught that hormone therapy was just too dangerous to touch.
Here's the wild part, though. When you dig into the methodology in our sources, there was a critical, fatal mismatch in who they decided to test.
Yeah, the demographics were way off.
I look at it like this. Imagine you want to test how a high-performance sports car handles on a tight, winding track. You wouldn't exclusively put 80-year-old drivers behind the wheel.
Right, because if they crash, you have no idea if the car's steering is defective or if you just had the entirely wrong drivers for that specific test environment.
Exactly. And the WHI researchers essentially put the wrong drivers behind the wheel.
That is a perfect analogy. The fatal flaw was their demographic selection. Because cardiovascular events like heart attacks and strokes are relatively rare in healthy 50-year-old women who are newly menopausal.
Right.
So the researchers faced a statistical problem. They needed enough cardiovascular events to measure within the time frame of the study to actually prove their hypothesis.
Yeah.
So to guarantee those events would happen, they purposefully recruited a much older demographic.
I mean, the average age of the women in the WHI trial was 63, and many were in their late 60s or 70s.
Right.
That is a full decade or more older than the age women typically go through the menopausal transition.
And most of them were completely asymptomatic. They hadn't had a hot flash in years. So the researchers took a population that already had years of age-related arterial stiffening and plaque building up in their blood vessels and suddenly introduced a high-dose hormone formulation.
Right, they weren't testing how hormones protect a 50-year-old transitioning into menopause with healthy arteries.
Exactly. They were testing how introducing hormones affects a 65-year-old whose cardiovascular system has been functioning without them for over 10 years.
And that distinction changes everything because introducing something into a healthy system to maintain it is vastly different from introducing it into a system that is already structurally compromised.
Absolutely.
Which leads directly to the second massive issue with the WHI, what they were actually putting into these older women's bodies. The sources call this the formulation fallacy.
Yes. If the WHI tested the wrong demographic, we have to look really closely at the specific drugs they used. They relied on the most popular formulations of that era. A drug called Premarin paired with medroxyprogesterone acetate, or MPA for short.
And let's clarify what Premarin actually is, because when you read the fine print, it is shocking. Premarin stands for pregnant mare's urine.
Yeah, it literally comes from horses.
It is a biological compound derived from the urine of pregnant horses. So we were giving 65-year-old women a massive dose of horse hormones. The obvious question is, how does the human cardiovascular system physically process an estrogen designed for a horse?
Well, it is a type of conjugated equine estrogen, or CEE, and that biological origin matters deeply on a cellular level. Premarin contains at least 10 different types of estrogens that are native to horses but completely foreign to human beings.
Wow.
And this is where the biochemistry explains the heart attacks they saw in the trial. Human cells have two main types of estrogen receptors, alpha and beta.
Okay.
Human estrogen binds evenly to both, creating a perfectly balanced physiological response. But the horse-derived estrogens in Premarin bind predominantly to the beta receptors.
And hammering those beta receptors creates a cascade of problems, right? Specifically inflammation.
Exactly. Heavy beta receptor activation triggers an increase in certain enzymes called matrix metalloproteinases, whose job is to break down collagen.
Wait, they break down collagen?
Yes. Now, think about the plaque sitting in the arteries of those 65-year-old women. Arterial plaque is actually held in place and kept stable by a fibrous cap made of collagen.
Oh, wow. So by giving them horse estrogen, the drug activated the enzymes that literally chewed up the structural collagen holding their arterial plaque together.
Precisely. It destabilized the plaque ruptures, blocks the artery, and causes a cardiovascular event.
That makes so much sense when you break it down like that.
And it gets worse because the WHI paired this horse estrogen with MPA, a purely synthetic progestin. We now know the precise mechanism of MPA. It alters liver protein synthesis in a way that dramatically increases insulin resistance and promotes the formation of blood clots.
You know, the sources use an analogy for this that completely reframes the conversation for me. Treating all hormones as a single class is like treating all alcohol the same.
Yes.
Like methanol and ethanol are both technically alcohols, but ethanol is what you enjoy in a cocktail at a restaurant, and methanol is industrial wood alcohol that will cause blindness or death.
Exactly.
We wouldn't say all alcohol is deadly just because methanol is, and we certainly wouldn't treat all beta blocker heart medications or all antibiotics as exactly the same.
No, we wouldn't.
But for 20 years, the medical community grouped all hormones together, assuming human hormones would cause the exact same damage as horse hormones.
It was a monumental scientific oversight. I mean, the modern clinical shift is entirely focused on isomolecular, often called bioidentical estradiol, known as E2, and micronized progesterone.
Right.
These formulations are chemically indistinguishable from what the human ovary naturally produces. Because they fit perfectly into the human alpha and beta receptors, the clinical data overwhelmingly shows they do not chew up collagen, they do not destabilize plaque, and they do not carry the clot-forming or metabolic risks of the synthetic and horse-derived versions used in 2002.
Okay, so plaque destabilization perfectly explains the cardiovascular scare. But here's where it gets really interesting. Because the headline that truly emptied the pharmacies in 2002, the one that paralyzed a generation of women with fear, was breast cancer.
Yes. The fear of breast cancer was the primary driver of that 79% drop in prescriptions.
But the data behind that fear is bizarre. Can you explain the placebo group anomaly in the WHI study? Because it's wild.
It really is one of the most profound statistical illusions in modern medicine. First, we have to remember the design of the WHI. It was a cardiovascular trial. The women were not randomized or balanced based on their baseline breast cancer risk.
Right, and when you look closely at the placebo group in that trial, there is this anomaly that skewed everything. It wasn't that the hormone group experienced a massive spike in cancer, it was that the placebo group's cancer rate artificially plummeted.
That is exactly what happened. But to understand why, you have to look at the concept of a hazard ratio. A hazard ratio simply compares the rate of an event in one group against another. In the WHI trial, about 25% of the women in the placebo group had actually been taking hormone therapy before the study began. To participate as a placebo control, they had to wash out, meaning they had to abruptly stop taking their hormones.
Ah, and because they had that prior exposure to hormones, they carried a lingering protective effect, what statisticians sometimes call a healthy user bias.
Right. And because of that lingering protection, this specific subset of women who washed out had an abnormally low annualized incidence of breast cancer during the trial. So if the denominator, the placebo group, is artificially tiny, the resulting ratio makes the hormone group look massive by comparison.
Wow.
The incidence in the hormone group wasn't actually higher than the general population of women who had never used hormones. The hazard ratio was artificially inflated by a statistical fluke in the control group.
It is genuinely infuriating to realize that a multi-decade global panic was driven by bad math.
It is.
And when you look at the 20-year follow-up data to the WHI, published in 2020, the narrative completely flips. The follow-up showed that the women who took the horse-derived estrogen alone, meaning they had had a hysterectomy and didn't need the synthetic MPA progestin, actually experienced a 45% statistically significant reduction in breast cancer mortality.
Yeah, the estrogen alone actually protected them, and modern data reinforces this on a massive scale. A nationwide Finnish comparative study tracked women using the modern isomolecular E2.
And what did they find?
They found that using E2, either alone or paired with a bioidentical progestin, for over 10 years reduced breast cancer mortality by up to 50% across all age groups.
That fundamentally rewrites the script, and we need to bring this into the real world for listeners who are breast cancer survivors. Because survivors are routinely told by their oncologists to avoid hormones at all costs. But the sources highlight a critical distinction for treating the severe pelvic pain, dryness, and tissue atrophy that comes from cancer treatments.
Yes. Many survivors are placed on drugs like tamoxifen or aromatase inhibitors. The entire biological purpose of these medications is to systemically starve the body of estrogen to prevent a cancer recurrence.
Right.
As a result, the localized tissues in the vaginal and urinary tract suffer severe atrophy, leading to chronic pain and frequent infections.
But the clinical consensus now states that low-dose, localized, topical, or vaginal estrogen is proven safe even for women on these estrogen-blocking drugs.
Because it is highly localized. A microdose of vaginal estrogen repairs the local tissue without significantly entering the bloodstream or spiking systemic estrogen levels.
That is so important for quality of life.
The American College of Obstetricians and Gynecologists, ACOG, is very clear. After shared decision-making, low-dose vaginal estrogen is an appropriate, safe, and highly effective option. We should not be condemning survivors to a compromised daily quality of life based on generalized, outdated fears.
Okay, so if systemic human estrogen actually reduces long-term breast cancer risk, and the earlier heart attack panic was just the result of older women reacting to horse hormones, what is the actual biological relationship between human estrogen and the heart? Because cardiovascular disease remains the #1 killer of women.
This brings us to a crucial concept in modern endocrinology known as the timing hypothesis, or sometimes called the gap hypothesis.
Right.
The physiological science now shows that estrogen is fundamentally protective of the cardiovascular system, provided you initiate treatment early. Specifically, the data indicates you want to start hormone therapy within 10 years of the onset of menopause, or before the age of 60.
I picture the timing hypothesis kind of like fixing a leaky roof on a house. If you apply a waterproof sealant the exact moment it starts raining, right when the menopausal transition begins, you protect the house perfectly. The structure stays completely sound.
I love that analogy.
But if you wait 15 years until the wood is entirely rotted, the drywall is crumbling, and the structural integrity is compromised, applying that exact same sealant on the roof won't fix the underlying damage. In fact, you might even trap the rot inside.
That is the exact physiological mechanism at play. Endogenous estradiol, the estrogen your body naturally produces, is the sealant. It plays a primary role in maintaining the endothelium, which is the intercellular lining of your blood vessels.
Oh, interesting.
Yeah, estrogen promotes the production of nitric oxide, a molecule that keeps blood vessels relaxed and elastic. It also physically prevents inflammatory cells from adhering to the arterial walls.
So the moment estrogen production shuts down at menopause, that daily protection vanishes, and arterial stiffening accelerates immediately.
Precisely. If you replace that estrogen early, you maintain the elasticity. If you wait 10 years, the plaque has already formed. But despite this incredibly clear mechanism, the official medical guidelines are still maddeningly contradictory.
Yet the sources dive into this contradiction. So what does this all mean for the listener? Because on one hand, you have the ELITE trial, which definitively proved that giving estradiol early significantly slows down the progression of plaque buildup in the arteries.
Yes.
But then the USPSTF, the U.S. Preventive Services Task Force, which dictates standard of care for thousands of doctors, recently gave hormone therapy a D grade for the prevention of chronic disease. Why would a government task force issue a failing grade if the biological mechanism and the trials show massive protection?
It fundamentally comes down to how these bureaucratic task forces filter and select their data. When the USPSTF issued that D grade, they heavily weighted the old WHI data, meaning they based their conclusion on the older demographic, the horse urine, and the synthetic clot-promoting progestins.
Unbelievable.
But the real tragedy is what they chose to exclude. They entirely dismissed one of the most profound modern long-term studies we have, the DOPS study, or the Danish Osteoporosis Prevention Study.
And they excluded it over a strict methodological technicality, right?
Exactly. The DOPS trial wasn't perfectly double-blinded.
Meaning?
Double-blinding means neither the patient nor the assessing doctor knows who is getting the real drug and who is getting a placebo. It's an important standard for subjective symptoms like pain or mood. But the DOPS trial tracked hard, objective outcomes over 16 years. They followed women who started estradiol right at the onset of menopause.
And the results were undeniable. The women who started hormone therapy early experienced a 52% reduction in heart failure and all-cause mortality, with no increase in cancer, stroke, or blood clots.
A 52% reduction in mortality is a massive life-altering statistic. But because the assessing doctors technically knew who was receiving the medication, the USPSTF threw the entire data set in the trash.
That is just wild.
As the authors of our source review passionately point out, you cannot placebo a heart attack. Mortality and hospitalization for heart failure are objective, binary outcomes. You either died or you didn't. By excluding real-world long-term registry data over a technicality, these task forces are making sweeping recommendations based on a highly distorted, incomplete view of the evidence.
And that distorted view is exactly why so many women are currently being denied preventative care by doctors who are just following the task force guidelines. But we've been hyper-focused on estrogen's role in the cardiovascular system, and there is a massive physiological blind spot here.
Oh, definitely.
Because the ovaries don't just stop producing estrogen or progesterone during menopause, they also drop production of a third hormone that is almost entirely ignored in women's healthcare: testosterone.
It is completely ignored because we culturally view testosterone as an exclusively male hormone. We associate it entirely with male puberty and aggression. But from a purely biological standpoint, healthy women produce significant amounts of testosterone, primarily synthesized in the ovaries and adrenal glands, and it is an absolute requirement for normal female physiological function.
The clinical data sources we are looking at show that when women experience androgen deficiency, when that testosterone production crashes, the symptoms are systemic and severe.
Very severe.
It is so much more than just a drop in libido. Women experience debilitating sleep problems, sudden bouts of depression, unexplainable weeping spells, massive spikes in anxiety, a sharp decrease in memory and concentration, and a dangerous, rapid loss of bone density.
And that wide array of symptoms makes perfect sense when you understand how testosterone operates in the female body. Women have androgen receptors densely packed throughout their brain tissue.
Really? In the brain?
Yes. Testosterone heavily modulates the production of neurotransmitters like dopamine and serotonin. So when testosterone crashes, the neurological balance crashes with it, leading to the anxiety and brain fog.
And it is just as critical for the skeletal system, right?
Absolutely. Testosterone directly stimulates osteoblasts, which are the cells responsible for building new bone tissue. Without it, the skeleton cannot maintain its density, accelerating osteoporosis.
Wow.
And the clinical data on testosterone implant therapy, where tiny compounded pellets are inserted safely under the skin for a slow, highly consistent release, shows drastic physiological improvements.
When you restore testosterone to healthy, normal female physiological levels, the benefits are profound. The sources show rapid improvements in lean muscle mass, restored bone density, and naturally, sex drive.
Right.
But more surprisingly, patients see massive improvements in cognitive clarity, mood stabilization, confidence, and a significant reduction in vasomotor symptoms, meaning the hot flashes and night sweats actually subside.
It treats the systemic failure. And the data specifically notes that testosterone pellet therapy is shown to be highly effective and safe, even in women with a history of breast cancer, because it can alleviate those severe symptoms without stimulating the breast tissue in the way systemic estrogen might.
But this brings us to the most frustrating reality of the current medical landscape, the absolute disparity in how we treat men versus women. I mean, if a middle-aged man goes to the doctor feeling sluggish and complaining of low libido, there are dozens of FDA-approved testosterone options ready for him. Gels, patches, injections, pills.
Dozens.
Do you know how many testosterone products are FDA-approved specifically for women? Zero.
Not a single one. It is a glaring institutional disparity in healthcare. Women's natural, healthy testosterone levels are roughly one-tenth of men's.
Okay.
Because there are no female-specific low-dose FDA products on the market, doctors who want to help their female patients are left in an incredibly difficult position. You cannot simply take a male testosterone gel packet and reliably chop the dose into perfect tenths without causing extreme erratic hormone fluctuations in the patient.
So how are women actually navigating this? If it's not strictly FDA approved for them, how do they get the physiological restoration the data supports?
This is where medical societies are having to step up to bridge the massive regulatory gap. ACOG now officially suggests that a clinical trial of testosterone therapy is highly appropriate for postmenopausal women dealing with hypoactive sexual desire disorder, provided other causes have been ruled out.
Right.
To safely administer that precise one-tenth dose, specialized doctors are relying on compounding pharmacies.
And compounding pharmacies are facilities that custom make the specific dosages of medications from raw ingredients, correct?
Exactly. Now, the FDA frequently issues broad warnings against using unregulated compounded hormones. But informed clinicians navigate this by utilizing strictly vetted pharmacies that voluntarily comply with high-level, rigorous quality assurance standards.
That makes sense.
This allows them to safely and accurately provide women with the exact low-dose bioidentical testosterone their bodies require. It simply requires a knowledgeable doctor to actively monitor the blood levels, ensuring the patient remains precisely within a normal, healthy female physiological range.
Let's bring all of this together. If you are listening to this, whether you are dealing with the menopausal transition yourself, or you are supporting a partner, a mother, or a colleague, the biggest takeaway from our deep dive today is this. You no longer have to blindly accept the fear-mongering and the institutional inertia of 2002.
You really don't.
You are now armed with the specific knowledge of formulations. You know exactly why horse-derived estrogen destabilizes plaque and bioidentical estradiol protects it. You understand the timing window, the critical importance of repairing the roof right when it starts raining.
Exactly.
And you have the hard data to have highly nuanced, scientifically grounded conversations with your doctor about estrogen, progesterone, and testosterone.
You have the physiological why. We now know that the transition isn't just about hot flashes. It is a fundamental shift in cardiovascular, neurological, and skeletal biology.
And looking at that biology raises a fascinating question that goes far beyond the walls of the doctor's office. We've talked deeply about the biological cost of ignoring this hormone deficiency, but, consider the socioeconomic cost.
Oh, it's massive.
Right now, millions of women in their late 40s and 50s are at the absolute peak of their careers, their expertise, and their earning potential. If vast numbers of that demographic are being sidelined by untreated brain fog, severe exhaustion, and physical pain simply because the medical system refuses to properly restore a standard physiological deficiency, what is that actually costing our global economy and our workplace leadership?
That is a staggering thought.
Imagine a world where that entire demographic remains fully energized, cognitively sharp, and biologically supported through the second half of their lives. That changes everything.
It completely redefines what aging looks like for half the population.
And they deserve those tools. Thanks for joining us on this deep dive.